So I've been asked to talk about meeting the dementia challenge through research. I'm not going to talk about all the very exciting things that are happening in research at the moment, but rather more, what does that actually mean? How are we going to deliver the research? What does this roadmap look like? I'm going to start with the summit declaration from, well, now the G7. And there were some very, very ambitious statements in there. I'm not going to go through all of them. Some of them have been met, such as having a global envoy. But one of them, I think, just needs a little bit of thought. This identify a cure or a disease-modifying therapy for dementia by 2025. It has a very sort of American feel to it. It's like, putting people on the moon, getting rid of cancer, etc. We have to be realistic, first of all, that we're not going to rid this planet of disease. We're not going to have everybody living forever. So we need to be realistic about what would success look like in terms of that first commitment. But the second point is that it actually says dementia. And I think that's important because a lot of discussions tend to conflate dementia with Alzheimer's disease. And that's quite a major error, particularly as we get older. All of us, as we get into our 50s and 60s, each of us has the right to have more than one diagnosis. Doctors don't like that, but I can have as many things wrong with me as I wish. And it's quite rare, as we move from that young onset person, to see Alzheimer's disease alone. So if we just think in terms of curing Alzheimer's disease, we're going to be disappointed. If we have a more nuanced understanding of dementia, then we're in with a chance. I think it's very important it was stated for dementia and not Alzheimer's disease. One's aware that these terms are quite often used interchangeably, particularly in the US, but that's partly their sort of political funding system. It's used in France because Alzheimer's is acceptable, but dementia isn't. This issue of stigma that we've already heard about. The other point I just want to draw is that third bullet point about increasing the number of people involved in clinical trials and studies on dementia, and I'll come to that in a moment. So moving on more specifically to the 2020 vision and how that's going to be delivered, the increased investment in research, well, it has improved significantly over the last couple of years, but I think we have to remember what the baseline has been. And it's absolutely horrendous. So in the UK, if you consider how much research spending per, £10 of health and care cost, for cancer, £1.08 is spent on research for each £10 of the care and health cost. For dementia, it's 8p. Now, those were figures from 2013, and it is improving. One has to recognise that there's still a massive gap. But even if we throw lots of money in, and money is going in, we don't actually have the dementia research workforce. I think one of the challenges is bringing people in from other specialties. It's been under-resourced, it's not as sexy as some scientific areas. We need to bring in lots of other specialties, lots of other medical specialties, engineering specialties, mathematicians, architects, sociologists, across the whole spectrum of researchers to put their mind to the dementia challenge. The other issue, and I said I'd come back to it, is this greater participation of people with dementia in research. And there were two particular challenges for 2020. One was that 10% of people with a diagnosis should be participating in studies. And that's really followed on from what was happening in the oncology field. It's easier there because a lot of the clinical equipoise, the decision you have to make about how you manage somebody, is how do you combine 2 or 3 anti-tumour drugs. So it's natural that if you're not sure, you'll put people into studies. There's lots of drugs to play with. It's different in the area of dementia, but it's to get people into research. At the moment, we're running at about 4.5% of people diagnosed with a dementia diagnosis. And the other relates to this registry of joint dementia research, which I will spend a little bit of time talking about. So if we accept that we need research, because we're not going to we're not going to meet the global challenge. And I don't just mean finding some wonder molecule, I mean research into how we manage care at the moment. We cannot mortgage care at the moment for some cure in the future. So it's across the whole spectrum. But how do we go from this 4.5% of current participation to get to that 10% by 2020? Well, the appetite for this is out there. So a YouGov and AR UK poll showed that when you ask people, 62% of people want to engage and very willing to participate in research, but only a fifth of them have any idea of how to do it. And at the moment, it is very much a postcode lottery in terms of research. It depends very much on the healthcare professional that is seeing whether they've got a research program or we're just too busy. I mean, despite the fact that I do a lot of research, when I'm actually seeing somebody in the clinic, I find it very, very difficult to think about research. It jars, it doesn't sit easily, even though I feel quite passionate that that's part of my professional delivery, is getting people into research. At the time you're actually dealing with somebody, it isn't easy. So what we've developed is something called Joint Dementia Research, and this is a partnership between the Department of Health and the charities Alzheimer's Research UK, Alzheimer's Society and Alzheimer's Society Scotland. And we've now got some 17,000 plus volunteers. The key thing about this, and I'll go a little bit further into what it does, but what it does is it flips, in a sense, the control of how you get into research to the patient and the public. So rather than just depending on the interest of the clinician, the healthcare worker that you see, it actually means that an individual can go onto a website or go through the charity or fill in a form. They become a data donor. They provide consent to use the data about them, about their diagnosis, and then that allows a matching to a particular study, and then it's a bit like looking at a menu and saying, well, actually, I'd rather like to go into that study, or I don't want to travel 50 miles to have that drug infusion trial, but actually I'd be quite interested in this local one that's taking my blood, or looking at care of distress, for example. And that switches it in terms of who has the control around going into research. So what it does is that the individual, and you can sign up on behalf of somebody, can go directly to the website internet, they can go through the charity helplines, or they can go through NHS memory clinics. And it's the third one I want to come back to, because that's where it really needs to go to meet the 2020 dementia vision. And what it does, so it aggregates the data about that individual, and for the future, this is a community of people, and coming back to Chris Norris's comments about the importance of patients and carers with dementia, this provides a community that you can get the advice from. It provides a community, to say, of data donors. And that also provides the consent to access people's electronic health records if they so wish, which provides an increased granularity of matching to studies. So you then match the study, and it says, well, I'd like to be emailed, I'd like to be telephoned, and then the researcher can contact the person, and hey presto, hopefully get into a study. These are some figures from about 3 weeks ago, just over 15,000 volunteers at that point. And it gives you some idea of where our volunteers are coming from. Quite variable. Lot of interest in the northeast, which has not been an area with a lot of research going on. So the appetite is there. Is it making a difference? So if it was a small study we did beforehand, people felt it was very difficult to know how to get involved in research in the dementia area. But afterwards, big increase in yes, much more aware, and yes, I now know how to engage in research. And has it made a difference to researchers? Again, the answer is, actually, I think there's a... Yeah. So what this is the percentage of recruitment into studies that are on joint dementia research. Now, we're still putting studies on all the time, and won't go into the sort of details of whether things are on the NHIR portfolio, etc. But studies are going on, and along the x-axis here are the number, the percentage of people that are being recruited into the studies that are on JDR. So Manchester here is way in front. I mean, nearly 50% of the people who engaged in studies in Manchester are recruited through joint dementia research. Much less down here. It's interesting that Yorkshire and Humberside, not so many, despite the fact that they're getting a lot of volunteers. So how are we going to get to those challenges in the 2020 vision document? The 10% of people with a diagnosis entered into studies, and 25% of people after a diagnosis registered on joint dementia research. Now that's a massive challenge, because what that means is if you think of the number of incident cases, the number of new cases in any 1 year, we've got to have around 23,000 people in that year after they've had a diagnosis going on to JDR, joint dementia research. The figures though work well, because if one achieved that, that means 10% of people with the diagnosis of a dementia illness will be in studies. So you hit both targets. What this shows, so this is the target for 2020, is that if we just carry on as we are, and every time there's a bit of media coverage there's a spike, well, we'll carry on increasing, but it's a wasted opportunity. NHS implementation, i.e. that people who are in memory clinics, people who are visiting care homes, people who are involved in delivery of care to people with a diagnosis of dementia, draw people's attention to JDR and help them to register. It doesn't mean say everybody's got to do it, and it doesn't mean people necessarily will go into the research, but they have the opportunity to do so. The NHS interface is just making it very, very much easier to do it. So if you're in a memory clinic, you want to talk, you've made a diagnosis, you're discussing the diagnosis, you want to then draw attention to JDR, or you actually can go to a little icon, click it, and then the information will be sent to that patient. Or they'll be told how to contact the help desks at the charities. And then last of all, which will make a big difference, and we're working on this at the moment, is actually interoperability with NHS IT systems. Because if I go onto JDR and I'm on JDR, I will give consent to have my electronic health records accessed. I'm quite happy about that. I can, if I want, put some constraints on what information I wish and do not wish to share, but then that will immediately match me in a much, much more precise way. That means the researchers are not wasting time getting people up and screening them and they don't enter the studies. If you get people in without wasting money, you get them in quickly, you get the answers quickly. Whether a positive or a negative answer, that's what we should be doing. And so, in terms of the value, for research, we know that people do just want to be involved in research, so that's at nearly 70% of individuals. And we know that people, when they have a diagnosis, value being involved in research. So part of the post-diagnostic support should be making that easy. And although it's quite difficult to actually get the data, there is increasingly emerging evidence that not only is research obviously a good thing at the population level, but it also is at the personal level. And people often do well. So when we started entering people into trials for Alzheimer's disease, and all the statistical analyses were based on a decline that we would anticipate in something like the Mini-Mental score when they were on placebo. In fact, it didn't work like that, because even the people who were on the placebo did better than we would have ever thought they would do so. And there's something about being in a trial, the monitoring, the care over comorbidities, and the very process of being in research is valuable. I said it's not only about finding a specific molecule or some disease-modifying intervention, the importance also of research on how best to care, and also research on carers. And published today from the NHIR Dissemination Centre are 5 studies showing the value and the cost effectiveness of putting in interventions for managing carers and carer stress. And a lot of research will need to go on in care homes, not only for those who have a diagnosis now of moderate to severe dementia, but because cognitive impairment is common as we get older and is common in a variety of comorbidities that will exist in those who need to go into care homes. About 80% will have some dementia diagnosis in care homes. The problem is it's very difficult to prosecute research in care homes. There is now enabling research in care homes of some 1,000 care homes that are signed up to being research enabled to be able to help to take this sort of research forward. And then just to finish off, I just want to come back to this issue of dementia. It's politically useful. We're doing very well to deal with the stigma of dementia, but it's not a particularly helpful concept. It's rather like thinking back in the 60s that, when cancer had a lot of stigma, and it would be a bit like waiting until a primary tumour had metastasized before we decided to make a diagnosis. So dementia is a statement around significant cognitive impairment. It's just that eighth of the tip of the iceberg that you see. And there's a massive amount of cognitive difficulties that range from those with adult learning difficulties to those of us who are developing some cognitive difficulties as we age. Now, some of those will go on in the very early stages of a diagnosis like Alzheimer's disease, but many of them are treatable. We see lots of disorders that can look like Alzheimer's disease, for example, sleep disturbances, that actually you can manage that cognitive impairment. So looking to the future, it's very important that as well as having people with a diagnosis of dementia, we also have people with very mild disorders, and we also have people in the general population to be able to carry out research on prevention. And I'll finish there. Thank you.